Hi, everyone. My name is Gabriel Atit. I'm a neonatologist at the Montreal Children's Hospital, and I'll be presenting to you tackling acute pulmonary hypertension in preterm infants through physiological and targeted approaches. These are my disclosure. I will mention off-label use of INO and some pulmonary vasodilators and inotropic support in preterm population. This is the QR code in order to access some of the material that I'm presenting here at Neoheart. And I would like to thank the organizing committee for inviting me to this wonderful presentation to share with friends and colleagues wonderful knowledge. So at the end of this presentation, the participant will be able to define acute pulmonary hypertension in preterm infant. We'll discuss some of the various phenotypes corresponding to what we call acute pulmonary hypertension in premature infants. And we'll talk about the current available literature on acute pH management in premature infants. So first of all, after birth, we know that there's a critical period of transition where there's lung expansion with mechanical stretch, exposure to oxygen, as well as production of some endogenous substances that will lead to a drop in the pulmonary vascular resistance. We know also that the systemic vascular resistance will increase due to the disconnection of the placenta. And eventually, many of these infants should get closure of the ductus arteriosus, although some of these mechanisms, as we know, might be disturbed in the context of prematurity. This is a wonderful schematic representation of some of the mechanisms that may happen in the context of birth. And we all know that if we're starting earlier, there could be many of these stressors that are leading to prematurity that may impact this transition and potentially disturbing the natural fall in pulmonary vascular resistance, as well as this natural rise in systemic vascular resistance. And knowing that all of the organs are interconnected, there might be eventually end organ damage. And so when we talk about an abnormal transition, we often think about some of these failure of the adaptation to extrauterine life, which can lead to this picture of what we call acute pulmonary hypertension. We think clinically of these babies that have respiratory distress and cyanosis and labored breathing, but we also know that this clinical presentation could be basically secondary to so many etiologies. And really, to be calling it acute pulmonary hypertension, I truly believe that you still need some kind of imaging like echocardiography to provide you more information on the underlying cardiovascular physiology. Now, some of the disturbers of pulmonary vascular resistance that we often see in the context of prematurity are things like hypothermia, infection, primary lung disease like having a high PCO2 or acidosis, as well as some stressful events that may occur in some of these babies like pain or seizure in the context of intracranial bleed. Sometimes some of the medications that we use like dopamine that can increase PVR. And so I do think that we need to start with the definition so we keep a common language and terminology. Typically, when we talk about hypertension, it's within the word, we speak about an abnormally high pressure. And because we're talking about the pulmonary compartment, we talk about abnormally high pressure in the pulmonary artery. We often refer to acute because it occurs in the first few days of life of these patients. But really, this high abnormal blood pressure is rather a symptom of an underlying process, and often we need to identify the cause to tailor the therapy. For example, an infection, we should probably provide antibiotics. If the baby's hypothermic, we should probably make him normothermic, make him or her normothermic. If there's hypoglycemia or hypocalcemia, we may need to normalize the electrolytes. And we often refer to acute pulmonary hypertension, or sometimes in some textbooks or literature as persistent pulmonary hypertension of the newborn, as referring to the fact that it's the resistance within the pulmonary vasculature that is too high and has not dropped. Too high for what we would consider or what we would expect as normal within this gestational age, which already on its own becomes a challenge to define. The fact that there's high PVR is assumed to lead to this decreased pulmonary blood flow, and eventually, because of this, we have some degree of systemic desaturation and hypoxia, which can lead to compromised oxygen delivery. And so I would like to go back some key physiological principles. First, we all know that pressure is a function of flow and resistance within a system. And so when you do have these abnormally high PVR, this can lead to either a flow that's maintained. If you're able to um, have, flow maintained, then typically it would lead to an increase in pressure. So you get a pressure that may be abnormally high. If the flow in this context is reduced, then the pressure may be what is expected for age because you drop your flow, you increase your resistance, and the pressure might be within what we would see in a healthy newborn or healthy premature newborn. And if the flow is dramatically reduced with high resistance, then that's when you start seeing low pressure, actually. So that's why when we use the concept of acute pulmonary hypertension, the word may not totally translate what we have in mind, which is probably the fact that we have abnormally supraphysiological PVR for the context of gestational age. Now, some of you will tell me, what is physiological in a baby that's born at 22 weeks? And that's totally a matter of another discussion. Boyle's law tells us that when two containers of gas are connected, the gas will flow between them and the pressure will equalize. So you have to remind yourself that when you have structures that are connected within the cardiovascular system, if these structures are connected by the tube that is not restricting pressure transmission, you will have equalization between the two containers. So within a PDA that's very large and not restricting pressure and flow, you will equalize your pressure on both sides of this ductus. So your P1 will equal P2 and your aortic pressure will equal PA pressure. Hence the whole idea that you may have very high PVR, low SVR, and still see the same pressure on both sides by regulating the flow through the duct. We also know that high afterload, which means the loads against which the RV has to press or bench press at the gym, for example, can lead to significant RV dysfunction and eventually compromise the output in the pulmonary artery. This will lead to a drop in the pressure within the pulmonary vasculature, but this may also occur in the context of high PVR. In this context, your PDA could be left to right. And sometimes you have to keep in mind that the PDA could be closed. And in this context, clinically, you wouldn't see, pre and post ductal differential of saturations. So sometimes what we see at the bedside may need more information in order to try to kind of discern all of these concepts of pressure and pulmonary vascular resistance relative to systemic vascular resistance. Which brings me to the concept of the balance between the pulmonary and systemic compartment. When you have right-sided pressure or resistance that are higher than systemic pressure or resistance, this may mean that the right-sided are abnormally high and compared to either left-sided that are also abnormally high but much higher on the right-sided. Maybe it's high and the left pressures are normal. So that's why you have, for example, a right to left shunt, but the left systemic pressure or resistance are normal. It could be that you have very low pressure on the systemic side and high pressure on the pulmonary side. But it could also be that you have a patient that's profoundly hypotensive due to E. coli sepsis, and you get a right to left shunt at the PDA level that is simply to generate flow because your aortic pressure is so low with normal PA pressure. So in this context, you would see a pre and post ductal saturation difference, and you might call it at bedside an acute pH crisis. And finally, you can have very low pressure everywhere with the right-sided abnormally low but higher than the left-sided. That's quite rare. It's typically when you get extremely severe pulmonary vasodilation and systemic vasodilation in the context of sepsis, and these patients often have severe pulmonary edema as well. And this is true for anywhere that you're going to try to assess the ratio between the pulmonary and systemic compartments. So let's talk about a few cases that may exemplify the richness in phenotypes that creates a challenge sometimes in some of the research standardization that we attempt to do. First, we have our classic patient, premature baby born in the context of Preterm, oligohydramnios. This patient has a disturbed transition to extrauterine life and a persistence of very high pulmonary vascular resistance. Because of that, there's increased RV afterload. There is right to left shunting at the atrial and ductal level because my LA is underfilled and my RE pressure might be a bit higher due to RV struggling to push against this high resistance. You get a volume of deoxygenated blood introducing hypoxic blood into the left atrium and to the systemic circulation. This leads to desaturated preductal limb. And eventually, this right to left shunt at the PDA level will also lead to a postductal desaturation with a differential of saturation. And this is due often because, well, you must have a PDA, and if it's unrestricted, you may get a high volume shunt creating this desaturation. So, by echo, we would see a duct with deoxygenated blood, shunting from the pulmonary compartment and entering the descending aorta. You may see, RV, LV, with RV dilatation and a parasternal short axis and some degree of flattening of the septum. And at the atrial level, you would see blue blood entering the right atrium to the left atrium, creating this desaturation at the preductal limb. And that's the kind of classic acute pH crisis that we see in these patients in the first few days of life due to stressors. And this is a 4-chamber view where you can see that the RV looks a bit muscular and with some decreased RV function. Now, in the same, context, you can have high PVR and this time a restrictive ductus. And these patients may have a bit less volume shunt going through the PDA and may not always present with these differentials of SAT if the amount of blue blood entering the systemic circulation at the ductal level is really a trickle. And so we do have the high PVR, we do have a right to left shunt at the atrial level, and sometimes this volume of shunt is quite excessive, especially if you get RV failure. And eventually you may or not see these pre-postductal saturation differences. And often you can see RV is struggling. This is tricuspid regurgitant jet. This premature baby has, an RV that is dilated, bowing towards the LV and parasternal short axis. And you see this PDA that actually looks bidirectional, very tiny, very restrictive, and with suprasystemic PA pressure at that point, because you don't get equalization of pressure on both sides of the duct since it's restrictive. You can also have the patient who has an acutely pH picture with very high PVR. And at that point, the RV has also taken such a hit that the degree of RV output is extremely diminished. Because you get almost none or sometimes no RV output due to the severely impaired RV function, you get a lot of backflow into your right atrium, bringing a lot of blue blood from your RA to your LA, making you very desaturated. But because your RV is basically not feeding anything or almost nothing inside your pulmonary artery, it's this time this LV that's providing blood flow to your pulmonary vasculature. We call this picture often functional pulmonary valvular atresia or stenosis because the RV is basically almost dead or not generating enough output, which creates the situation of left to right shunt at the ductus. And these patients may also be considered to have some degree of acute pulmonary hypertension because they have the failure of mechanism of drop of PVR, but a concomitant RV significant failure. And so these patients will typically be very desaturated and not really showcase, differentials of SAT. They may all be profoundly desaturated because the volume of right to left shunt at the atrial level may be excessive, especially in the context that these patients have low pulmonary blood flow and decreased left atrial pressure. And so this is an example of a patient preemie. This is RV outflow tract where you can see here the Doppler, which is extremely tiny and outlining that there was almost no RV output. And then this patient had a, right to left shunting at the atrial level and left to right shunting at the ductal level. One other picture could be an acute pulmonary hypertension without a duct. So some of these patients may have either closed prenatally or closed early postnatally. And in these patients, actually, you get high PVR, high RV pressure, and the RV may fail, leading to backflow into your right atrium, significant hypoxia, and you won't see any pre and post ductal saturation differences because there's just no duct. And so these patients will typically appear like this, where you scan, there's no duct. You see an RV that's struggling, in this context, hypertrophied, and you see that there's right to left shunting at the atrial level. Finally, sometimes you can have mimickers or contribution of biventricular dysfunction. When you have significant LV failure, these patients may have absolutely no output or very limited output into their systemic vasculature. And because of that, it's the RV that's pumping a right to left shunt via the duct and sending blood flow to the systemic circulation. And in this context, this duct is absolutely essential to maintain systemic output. These patients will often have high left atrial pressure because the LV is failing. And because of that, you get left to right shunt at the atrial level. And if you have normal lungs, your preductal sat may be completely normal. If your lungs are damaged because you have significant RDS, you have abnormal, VQ mismatch, and these patients could also be desaturated because the pulmonary venous blood is desaturated. Often these patients will have pre and postductal saturation differences simply by the fact that they have right to left shunt at their ductal level. So this is an example of a patient who has biventricular cardiac dysfunction, but you can see that the LV is almost not moving. And because of that, you get this PFO, which is quite restrictive, high velocity, and it actually unloading the left atrium into the right atrium. Here you can see the duct, which is right to left from the pulmonary artery to the aorta, bringing deoxygenated blood to the descending aorta. And in this context, you can see that there's biventricular dysfunction in this apical view, and you can also appreciate the significant LV dysfunction in the short axis view. But there are many more variations. Patients with small or no PFO, duct becoming restrictive, concomitant underfilling, concomitant parenchymal lung disease, and name it. And so I think this richness in phenotypes create a challenge in research standardization. We all know the report from the American Academy of Pediatrics, which has outlined the countless RCTs that have been done in INO in the context of prematurity, most of the time trying to see if it would prevent BPD, or in the context of what we call hypoxic rest failure. And so the AP mentions that results from RCT indicate that neither rescue or routine use of INO improves survival in preterm infants with rest failure, and that the evidence does not support treating preterm infants with INO when they have rest failure in order to prevent or ameliorating BPD, severe IVH, or other neonatal morbidities. Now, the problem is that hypoxic rest failure can be secondary to many things: lung disease, RDS, cardiovascular, acute PH, because if you have no or low blood flow, you're going to be hypoxic. It could be cardiorespiratory conditions, so parenchymal disease with high PVR. It could be infectious, septic, and so many other things. Now, the Canadian Pediatric Society, for which I'm the author of the practice point with Dr. Mitra, we did mention that the diagnosis of PPHN should be established with echo, ideally before initiating INO. And if possible, if not possible, that the echo should be actually obtained at least, thereafter. And that in very preterm or extreme preterm, INO could be considered and initiated at 5 to 10 ppm in this particular context. And so it could be used as a rescue modality in preterm infants with early onset refractory HRF, which have confirmed by echo pulmonary hypertension, and especially when it's associated with PPROM and oligo. And it could also be used in preterm infants who have BPD and severe pulmonary hypertension later down the road. Now, if you look at evidence from various trials, there are not that many. This is the Pinot trial from the group of Dr. Schock. They extracted the 12 patients who had PPROM, oligo, and pulmonary hypoplasia, and they found that in this particular subset of patients, it did seem to decrease to some degree mortality and potentially even decrease BPD. Recently, at the Canadian level, we extracted 426 preterm infants data that were exposed to INO, and we looked at early and late pH. I'll focus on early pH, where we've seen that these patients were started at a median of day of life 1, with 90% having some concomitant lung disease on high frequency ventilation and a high amount of oxygen response need. And we could see that those who decreased their oxygen need by 20% after INO had a much decrease in mortality using a Kaplan-Meier test. We also have other groups that describe similar setups. So this is a group from California who analyzed 270 infants with prematurity exposed to INO, and they actually did not find improved survival in those patients with some degree of pulmonary hypertension. They actually saw that INO was probably just a reflector of their lung disease. The group of Toronto actually published a few years ago where they looked at responders. Um, and what they found was that younger postnatal age and pH on echo were actually predictive of INO response regardless of gestational age. And among those who were less than 72 hours, there was a greatest response. The group from Toronto also published on 89 neonates that were preemie and exposed to rescue INO. They found a positive response in 46%. And they did find that those responders had improved survival without disability, lower mortality, and less disability among the survivors. It was found also that if there was acute pulmonary hypertension context of pre-prom for more than 2 weeks, or a positive response to INO, these were associated with better outcomes, and early pH was associated with a higher response rate to INO and lower mortality. The group from Iowa also published on their experience in the extremely preterm infants, and they found that those who had positive response had received INO earlier, had acute pH on echo, and had decreased death for grade 3 BPD when they had a positive response. And I do want to bring you to the attention that on the, in the community, there's still a lot of struggling feelings regarding the use of INO. And we have to acknowledge that there is so many various elements at the bedside when we're trying to make decisions of what's best for our patients. So how do we finally manage these patients? Well, I do think that as I outlined, the richness in phenotypes creates opportunities to provide precision medicine. And until we have better evidence from trial, I do believe that physiology-driven care is a reasonable approach to tailor therapy. And so I want to bring you back to this, Sentinel article and review by Dr. Gissinger, who really outlined some of the key findings of patients who have HIE, actually. But I do believe that these concepts are applicable to the acute pH pictures that we see in the NICU, even in the context of prematurity, and where basically you're able to tailor your management based on the phenotype underlying your patient. And so we know that when you have high PVR and a hypoxic rest failure, you should optimize ventilation, you should consider surfactant for RDS, you should have appropriate pulmonary recruitment, normalize temperature and glycemia, and sometimes provide a bit of sedation, analgesia if the patient is really in a state of discomfort to avoid reactive increase in PVR. We should titrate oxygen as per evidence-based saturation limits. And I do believe that all of these are also applicable to the physiology of some of our preterm babies until at least we get more data. I think that, stressors should be addressed in these patients, but if we do have high PVR, despite addressing and optimizing all of these elements, I do think that considering INO in this subgroup of patients, especially if they had sign of pulmonary hypoplasia or acute pH in the context of pre-prom, INO could be considered as one of the modality to decrease PVR, knowing that we should wean it if there's no response, or eventually wean it when our physiology has reverted, because these patients are quite fragile. If there is ventricular dysfunction, then probably you need inotropic support or sometimes even PGE to reopen the duct, because sometimes, you may have such degree of compromised output that you're entering a realm of almost single ventricular physiology, such as in the context of functional pulmonary atresia. And in certain situations, when you have preserved LV function, high pulmonary vascular resistance, and depressed RV function, you could consider vasopressin or norepinephrine. Sorry, this is mistake, not Milrinone. Vasopressin or norepinephrine. I did put here, one table that I use to classify some of the agents, knowing that we just don't have great data of trials in patients that are preterm, while some of these babies that are preterm are probably the most fragile and the most, at risk of having some of these high PVRs from birth and some degree of RV or LV dysfunction. I also provide this wonderful figure from Satyan and Martin Kessler that I've, bonified with some of the new agents, and remind you that these agents have never been trialed or studied in great length in the context of prematurity, but these agents are what have been described to act directly on the pulmonary vasculature to create a pulmonary vasodilation. So in conclusion, preterm infants are at risk of a disturbed transition to extrauterine life, leading to failure, PVR dropping, and hypoxic rest failure. Not all hypoxic rest failure are actually acute pulmonary hypertension. They may be other etiologies, and they should be targeted as such. I do think that terminology is important. An acute page may represent various phenotypes. ECHO does provide you with enhanced diagnostic to tailor your therapy. And until more trial evidence, management based on comprehensive assessment may provide precision medicine and improve outcomes. I do think that a lot of future studies are needed so that we can isolate these phenotypes and use potentially targeted neonatal echo to assess some of the pharmacological strategies. Thank you for comments, and I will be open for questions, or you can send them to me by email. I hope you enjoyed this presentation and hope to see you at Neoheart.